Orthopedic surgical procedures have become more complex and have increased the demand for bone grafts, bone substitutes, and bone growth factors. Bone was one of the first tissues to be transplanted. In 1820, Philips von Walter used autograft bone to fill trapanotomy defects. Bone remains one of the most frequently transplanted tissues in the human body. Recent procedures have placed great demands on the source of bone, expanding the roles of graft sources. The objectives of this surgeon education guide are to review the current state-of-the-art of modern bone grafting materials. This document will review the mechanisms of bone healing and current bone grafting options, and will aid the surgeon in choosing the best tools for the treatment of his or her patients. The information provided in this monograph is not intended to represent a specific algorithm for treatment, which must be individualized according to specific problems associated with a given case. Bone grafting to augment skeletal healing is a standard clinical practice. In situations of significant bone loss, delayed union, non-union, or fusion, the use of bone grafts can benefit the clinical outcome. It is estimated that 700,000 bone graft cases are performed annually in the United States alone. Historically, there have been many approaches to bone grafting, with the technology continually evolving. Autograft, generally obtained from the iliac crest, is the most widely used bone graft material today. While it is considered the gold standard in terms of biological response, the use of autografts are in decline due to the limited supply and morbidity associated with the harvest procedure, which can occur in as many as 25 to 30% of patients. While commonly used by clinicians, the performance of allograft has not been shown to be at the same level as autograft, and the quality may be variable. But it is available in a wide variety of shapes and forms for multiple uses. Although the possibility of disease transmission is often cited with respect to bone allografts, it is estimated that the risk of viral transmission by unprocessed allograft is extremely low because of donor screening, that is about 1 in 2 to 8 million. Completely synthetic substitutes without a biological component have the advantage of laboratory synthesis with excellent batch-to-batch uniformity, and thus can be formulated to have specific handling characteristics, in vivo residence times, and variable delivery systems without the risk of disease transmission. However, completely synthetic substitutes rely on the body's local ability to regenerate bone, which may result in a poor outcome if this local ability is not ideal. Bone is a complex organ containing calcified bone matrix, bone cells, non-osseous cells, blood vessels, nerves, and marrow. The structure of bone can be described at many levels. For the purpose of this monograph, composition rather than structure will be emphasized. The wet weight of cortical bone is approximately as follows: 20% water, 45% mineral phase, and 35% organic matrix. The organic matrix consists of over 90% type 1 collagen fibers. The remainder consists of non-collagenous proteins, proteoglycans, and phospholipids. Importantly, the matrix also contains bone morphogenetic proteins. A type 1 collagen molecule is comprised of 3 polypeptide chains. The molecule is about 78 nanometers in diameter. The organic matrix is principally a 3-dimensional cross-linked array of the type 1 collagen molecules. The collagen gives bone flexibility and tensile strength. It also provides locations for the deposition of the mineral phase of bone, which gives the bone rigidity and compressive strength. The mineral phase of bone consists almost entirely of hydroxyapatite crystals. These small crystals measure about 50 by 50 by 400 angstroms. The crystals, however, can be of different forms, being described as tablets, rods, or needles. The bone material is not pure, but contains other ions by way of substitution, such as magnesium, sodium, hydroxyl, carbonate, and fluoride. The repair or regeneration of bone is a complex symphony of cellular activities that are mediated by both biological and mechanical signals. A basic understanding of the pathways of bone development will aid in understanding the healing process. There are two embryological pathways by which bone is formed: endochondral ossification and intramembranous ossification. During endochondral ossification, cartilage is laid down and then transformed to bone. In the case of intramembranous ossification, bone is laid down directly without an intermediate cartilage phase. The long bones, short bones, that is, carpal bones, ribs, and pelvis develop embryologically primarily via the endochondral route, while the clavicle and most of the skull develop via the intramembranous route. The ossification routes, however, are not exclusive to a given bone type. Bones grow in length by endochondral ossification and in width by intramembranous ossification. This is because bone is directly deposited on the outer surface of the bone by osteoblasts, originating in the periosteum. Mesenchymal cells, or stem cells, are pluripotential, capable of differentiating into bone, cartilage, ligament, muscle, tendon, or fascia. These cells originate from either the deep cambium layer of the periosteum or from the bone marrow. Signals from the local environment direct these cells to differentiate and express themselves as needed. Osteoblasts are the primary bone-forming cells, derived from the mesenchymal cells. Osteogenesis, or ossification, is the process by which the osteoblasts lay down the organic matrix. Mechanical stress applied to tissue can trigger differentiation of mesenchymal cells into osteoblasts, a process that requires 2 to 3 days. Osteoblasts create the organic matrix of bone, upon which mineralization later occurs. The initial, unmineralized, or uncalcified matrix is called osteoid. Osteoblasts lay down osteoid at the rate of about 1 micron per day. After osteoid is laid down, there is a mineralization lag time of about 10 days before mineralization occurs. 60% of the mineralization occurs during the first few days, the primary mineralization period. During secondary mineralization, the remainder of the mineral is deposited at a decreasing rate over the next 6 months. When mineralization occurs, the tissue is called bone. Once an osteoblast has surrounded itself with the organic matrix, it lies within a lacuna, or small cavity, and henceforth is known as an osteocyte. The osteocytes extend cytoplasmic processes through canaliculi, or small channels, thereby connecting with neighboring osteocytes. Osteoclasts are large, multinucleated cells that lie on the surface of bone. These cells are thought to derive from the fusion of many pluripotential stem cells, such as monocytes or macrophages. They act to resorb bone. Osteoclasts remove matrix by enzyme dissolution and bone by acid demineralization. Osteoclasts can erode tens of microns of bone per day. Bone formation and resorption is a constant process, responding to the needs of the growing skeleton, as well as in response to the physical stresses placed on the bone. Wolff's law describes the remodeling of bone that occurs in response to stress, with bone deposited in sites subjected to stress and resorbed from sites subjected to little stress. It is unknown what mechanism is used when mechanical load influences bone remodeling. It is believed that Wolff's law is mediated by induced electrical potentials. When a long bone is bent, a negative electrical charge forms on the concave or compressive side, while a positive electrical charge forms on the convex or tensile side. It appears that negative electrical charges induce bone deposition, while positive charges induce bone resorption. This forms the basis for clinical electrical stimulation to enhance the healing of delayed unions. Another theory is that strain in the bone may deform the processes of the osteocytes within the canaliculi of the matrix directly or indirectly through changes in hydrostatic pressure within the bone. There is evidence that such strain also affects the anabolic activity of osteocytes and that the absence of strain leads to bone resorption. Bone fracture healing is a complex, multifactorial topic and must be approached at many levels, including grossly and at the cellular molecular level. Grossly, after fracture of cortical bone, bleeding occurs, interrupting the normal blood supply to specific bony areas around the fracture site, which leads to cell death and necrotic bone formation. A blood clot forms, typically encompassing both fracture ends. Capillaries from the periosteum and endosteum invade the clot, transforming it into granulation tissue. Osteoblast, probably from these membranes, proliferate in the granulation tissue. Within 3 weeks, a collar of woven bone, or primitive, unorganized bone, forms around the fracture gap, called the periosteal callus, which helps to stabilize the fracture, although some mobility remains. Within the next few weeks, the callus transforms into mature lamellar bone, which has increased organization. When this strong collar eventually completely stabilizes the region, the fracture is clinically united. After union, the excess callus disappears. The medullary cavity is further reformed through bone remodeling along the stress lines. When this is complete, the fracture is said to be consolidated. Typical healing times vary with the location, that is, distal radius, 6 weeks, humeral shaft, 12 weeks, tibial shaft, 18 weeks, and femoral neck, 24 weeks. Cancellous fractures heal faster than cortical fractures due to the enhanced blood supply. Little callus is formed. If a fracture is openly reduced and internally fixed, with the fracture ends in direct apposition, and excellent stability is achieved, then healing may occur via osteonal remodeling across the fracture line. Almost no periosteal callus forms when this primary fracture healing occurs. When internal fixation is not used and stability relies substantially on the formation of callus, secondary fracture healing occurs. Fracture healing may be divided into 3 biological phases: the inflammatory phase, the reparative phase, and the remodeling phase. During the inflammatory phase, lasting 3 to 7 days, pain and swelling effectively act to hydrostatically splint the fracture. A hematoma forms. Inflammatory cells infiltrate the site, and there is vasodilation and serum exudation. Chemical mediators recruit stem cells to transform into cells that mediate bone formation. At that stage, if errors are made in the normal biological cascade, including poor initial immobilization, then there is typically no way to correct the situation by manipulating the existing group of reparative cells. Consequently, bone grafting, ultrasonic, or electrical stimulation may be required. The reparative phase lasts 1 month. During this phase, a periosteal and medullary callus forms. At the site of the fracture, both endochondral and direct, or intramembranous, bone formation occur. If there is inadequate vascularity caused by insufficient immobilization, the mesenchymal cells tend to differentiate into chondrocytes, which lay down cartilage, which is further replaced by woven bone. It takes about 1 to 2 weeks to observe substantial volumes of woven bone and cartilage tissue within the callus. This early reparative phase healing is known as provisional callus. As mineralization proceeds, this callus becomes increasingly rigid and is then referred to as bony callus. Because the bony callus has a larger cross-sectional area than native bone, despite less strength than cortical bone, the overall structure can be as strong or stronger than native bone. Bony union has been achieved when motion between fragments ceases, completing the reparative phase. During the remodeling phase, through both osteoblastic and osteoclastic activity, the medullary and periosteal calluses are resorbed, and the remaining woven bone or calcified cartilage is replaced by mature lamellar bone, which can be cortical or cancellous as the site dictates. Through remodeling, the biomechanics of the new bone are restored to be consistent with that of the surrounding bone. This is a gradual process, and radiographic evidence of the fracture can persist for many years. The function of a bone graft may be defined through three basic pathways. 1. By adding a competent osteoconductive surface for migration and attachment of pluripotential mesenchymal stem cells. 2. By implanting pluripotential mesenchymal stem cells in the injury site, thus the basis for autogenous bone grafting and autogenous cell concentrating systems. And 3. By osteoinduction, using a variety of proteins that coexist in the autogenous bone graft harvest to provide a stimulatory effect for bone information. Augmenting a fracture or non-union site with all three components may therefore enhance the rate of fracture healing or graft incorporation and reduce risks of non-unions. Essentially, the function of a bone graft is to recapitulate the natural stages of fracture healing using osteoconductive materials, osteoinductive proteins, and osteogenic cells. To fully understand the function of a bone graft, it is important to first understand the biology of fracture healing. The fracture healing cascade involves modulation of three components: a conductive matrix, inductive biologic cell stimuli, and osteogenic cells. At the time of fracture, there is an immediate binding of multiple plasma proteins to the matrix present at the fracture site. This matrix may be anything from the fibrin clots that keep both ends together to a bone graft material implanted by a surgeon. This matrix is crucial to new bone formation and must present a substrate with specific surface kinetics and three-dimensional architecture to facilitate the attachment of migrating pluripotential mesenchymal stem cells. Matrices that fulfill these requirements are called osteoconductive. The appropriate migration of cellular components to the site of a fracture or bone graft is crucial for the fracture healing cascade. Osteoconductive bone graft substitutes allow migrating pluripotential stem cells to populate a fracture site and start new bone formation. Modulating this entire process are the osteoinductive factors. These proteins may provide the chemotactic and/or mitogenic stimulation to the osteoprogenitors. The fracture healing cascade is enhanced by some of these osteoinductive factors which promote the migration of the pluripotential stem cells to the fracture site through a chemotactic process. In addition, osteoinductive factors may be involved in cell proliferation through a so-called mitogenic effect. It is important to note, however, that despite the use of osteoinductive factors, an appropriate osteoconductive matrix must be provided to these cells for migration and attachment. Many peptide signaling molecules, such as fibroblastic growth factor, platelet-derived growth factor, insulin-like growth factor, and vascular endothelial growth factor, stimulate the activity of chondrogenetic and osteoprogenitor precursors, mature chondro and osteoblasts, as well as other responsive target cell lines, without affecting cell differentiation. As a result, these molecules do not directly stimulate bone formation and are therefore known as osteopromotive factors. These peptides are not tissue-specific in that they promote tissue repair, regardless of the nature of the tissue and the location. They are typically released by activated platelets that invade any type of injury site. This is the rationale behind clinical use of autogenous platelet gels or platelet-rich plasma, as it represents a rich source of multiple growth factors, which help to enhance the body's own processes of bone formation. The second major type of inductive proteins involves the family of bone morphogenetic proteins, or BMPs. BMPs stimulate chemotaxis, differentiation, and mitogenesis of undifferentiated perovascular mesenchymal stem cells, leading to the formation of osteoprogenitor cells and bone deposition. In other words, the direct formation of bone via protein-induced stimulation. These factors are osteoinductive, in that they will form bone irrespective of the implantation site. Bone grafts and graft substitutes are characterized by several properties, as shown in Figure 1. These different materials vary in chemical composition, physical structure, and biologic behavior. Purely osteoconductive materials are conducive to bone formation in a well-vascularized, stable bone defect, whereas true osteoinductive or osteogenic materials are needed to stimulate bone formation in areas where bone is not naturally formed, such as a posterolateral spine fusion. The evaluation of efficacy of one bone graft preparation over another is hampered by a relative paucity in comparative human studies, variability of the physiology of bone grafting between species and between anatomic locations, and the uncertain ability to extrapolate animal data to humans. Fresh autologous bone has long been the traditional source of bone graft. The most common form of autologous bone graft is cancellous bone, harvested from the iliac crest, distal femur, or proximal tibia. Autologous cortical bone is occasionally used, but sources are limited to strips of the iliac crest, segments of the fibula, or ribs when approaching the spine through the thorax. Allogenic bone, taken from tissue donors, is a more versatile source and is available in whole or partial segments of most long bones, in the form of small cancellous blocks and demineralized bone matrix. Demineralized bone matrix, or DBM, is derived from acid extraction of allograft cortical bone. It contains osteoinductive factors, including bone morphogenetic proteins. Bulk bone grafts are available with attached tendons, such as the Achilles tendon calcaneus graft or the patella-patellar tendon tibial tubercle graft. Allografts may be fresh or processed and stored by one of several methods for later use. While there are many sources of allogenic bone, not all allografts are equal. Methods required for cleaning and processing allogenic bones affect the amount and availability of native BMPs. Grafts that still maintain larger and/or more available amounts of BMPs are more osteoinductive grafts than those that do not maintain any detectable levels of BMPs. A large variety of synthetic bone graft substitutes are available, including several calcium sulfate and calcium phosphate preparations. These materials, which are designed to mimic the mineral phase of bone, are typically available in a granular or paste form. When inserted into a bone defect, they slowly remodel into normal bone. All synthetic bone graft substitutes are osteoconductive, but vary in composition, rate of resorption, mechanical strength, and handling. These materials have no osteoinductive activity when used alone. A variety of signaling molecules influence the bone healing process. These include BMPs, which are now available in the form of genetically engineered synthetic molecules. These molecules are potent osteoinductive agents, and when given in supraphysiologic doses, have been shown in animal models to consistently lead to the healing of bone defects similar to that expected with autograft. There are, however, still significant side effects to the use of BMPs, such as formation of overexuberant bone and eggshell bone, which are bony envelopes surrounding soft tissue. Long-term concerns are also raised regarding the dosage required for these BMPs to be effective, which is more than 1 million times the physiological dose. A readily secure and available source of autologous growth factors are found in platelet concentrates and cells obtained from the patient's own blood concentrate, the so-called Buffy coat. Autologous mesenchymal stem cells aspirated from the patient's iliac crest may be further concentrated to specifically retain osteoprogenitor cells within graft materials. Preparations of bone grafts containing autologous stem cells thus have greater osteogenic potential. Finally, there are a number of commercially available bone graft substitutes that represent combination products, typically a mixture of an osteoconductive material with some form of osteoinductive agent. Autogenous bone has long been considered to represent the best material for bone grafting, but its use is limited by donor site morbidity and autogenous bone availability. Autogenous bone contains all of the ingredients known to stimulate bone healing, namely an osteoconductive matrix, osteoinductive signaling molecules such as growth factors, and osteogenic cells capable of responding to these signals. The presence of viable mesenchymal stem cells in autograft is the reason that autografts remain the gold standard for bone grafting. Allograft bone has long been used as an alternative to autogenous bone. However, allogenic bone is remodeled and incorporated much slower than autograft and typically exhibits biological performance not at the level of autograft. The quality of the graft may also be variable. Although potentially more osteogenic than processed allograft such as DBM, demineralized bone matrix, or cancellous chips, fresh allograft bone is rarely used because of logistic problems with its preparation, maintenance of sterility, and increased potential for disease transmission. Therefore, most allograft bone preparations have no osteogenic potential compared to autologous bone graft. Frozen or freeze-dried allograft bone is primarily osteoconductive and sometimes osteoinductive. Frozen grafts are preferred over freeze-dried bones because the freeze-drying process degrades the mechanical properties of bone, further limiting its application in situations where structural support is needed. Finally, some believe that allografts may elicit an immune response and thus be detrimental. In addition, while today's allografts are processed to eliminate most risks of disease transmission, the perception of a potential risk still exists. Synthetic substitutes without a biological component have the advantage of laboratory synthesis with excellent batch-to-batch uniformity. They can be formulated to have specific handling characteristics, in vivo residence times, adapted delivery systems, and no risk of disease transmission. However, synthetic substitutes rely on the body's ability to regenerate bone and may have a poor outcome if this ability is compromised. A number of bone graft substitutes are available for clinical use and can be broadly categorized into several groups. Although most are osteoconductive, they have minimal osteoinductive or osteogenic ability by themselves. Furthermore, the various bone graft substitutes vary significantly in their degree of resorption, ability to be remodeled, handling and load-bearing characteristics, and cost. Calcium sulfate, or plaster of Paris, has been used as a bone void filler since the 1950s. It is rapidly resorbed and replaced by bone. In fact, it resorbs too quickly to provide a support for bone formation. Calcium sulfate preparations have been inconsistent in their crystallinity and therefore have unreliable mechanical properties. Today, a medical-grade calcium sulfate preparation is available and is used clinically as an antibiotic depot and as a filler for stable bone defects, such as a metaphyseal defect following fracture, or for treatment of a benign neoplastic lesion, such as a bone cyst. Ceramics are a class of compounds with a highly crystalline structure made from the sintering of natural mineral salts. Hydroxyapatite is a ceramic derived from tricalcium phosphate and is a very stable biocompatible compound with excellent osteoconductive properties. Because of its highly crystalline form, it is very slowly resorbed by creeping substitution. Some hydroxyapatite compounds have been synthesized or made from processed coral. Specific species of sea coral contain a calcium carbonate exoskeleton closely resembling the microstructure of bone. This material can be chemically converted to calcium phosphate and is commercially available as blocks of graft with pore sizes of 200 or 500 microns. Although this material has highly compressive strength, it is brittle and resorbs very slowly, making it unsuitable for load-bearing applications in the spine. Its main application has been in tibial plateau fractures, where it serves as a filler material. Calcium phosphate cements were developed to improve the handling characteristics and resorption of the tricalcium phosphate ceramics. These compounds have a chemical structure similar to dollite, the predominant mineral in bone. These materials are created at the time of use by mixing powdered calcium phosphate and/or calcium carbonate with liquid sodium phosphate or saline. The resulting paste hardens in an isothermic reaction and forms an osteoconductive compound with excellent compressive strength. A potential disadvantage of calcium phosphate cements is their poor resistance to shear or tensile forces. Early clinical experience with these compounds with high crystallinity has shown that they are incompletely resorbed in humans. Poorly crystalline calcium phosphates are known to resorb quickly and more naturally. In this chapter, a variety of clinical applications pertaining to the use of bone graft substitutes are presented. The following case involves the use of an osteoconductive bone graft substitute in a delayed union of a clavicle fracture. The patient was a 70-year-old male who sustained a midshaft fracture of the right clavicle. Initial attempts to treat him non-surgically resulted in a delayed union. Internal fixation with the Rockwood clavicle pin and alpha BSM, bone substitute material, was used. The rationale behind the approach was that the clavicle pin would stabilize the fracture without the drawbacks of traditional hardware, and the alpha BSM would optimize the fracture healing environment and bridge the fracture. The patient underwent internal fixation under general anesthesia. Surgical examination confirmed that the patient had a fibrous union through the fracture site. In addition, a butterfly fragment from the original injury was grossly displaced, but connected to the fracture site by fibrous tissue. The fracture site was approached through a small exposure, and the fibrous tissue was debrided from the medial fragment. Next, the medial fracture end was clearly exposed and brought up through the surgical site. The medial canal was pre-drilled to allow clavicle pin insertion. Before the pin was inserted, alpha BSM was transferred to a syringe fitted with an angiocath catheter, which was inserted into the lateral fragment. ABSM was injected, acting as osteoconductive filler within the medullary canal, filling any possible non-visible bony voids. The clavicle pin was inserted in a retrograde fashion and allowed to pierce the skin laterally. The alpha BSM injection technique was repeated with the medial fracture fragment, and the clavicle pin was passed into the intramedullary canal. The clavicle pin reduced the fracture and applied compression across the fracture. Fracture fixation and proper pin alignment were confirmed intraoperatively using C-arm fluoroscopy. The hex nuts were applied to the end of the Rockwood clavicle pin and cold welded in position. After confirming the proper clavicle pin position, alpha BSM was applied to the fracture seam to assist the healing process. Soft tissues were then sutured over the repair and the surgical wound closed. Post-operative radiographs showed proper alignment and fixation of the delayed union. Repeated radiographic follow-up indicated continued healing and the formation of new bone. Subsequently, the Rockwood clavicle pin was removed under local anesthesia and IV sedation post-open reduction internal fixation. The patient was fully healed and returned to pre-injury activity levels. At 6 months, the patient continued to do well with full free range of motion of the involved shoulder. There was no pain or palpitation of the former fracture site, and the incisions were fully healed. The patient was released from care with a favorable outcome. The indications for the use of platelet-rich plasma in acute trauma and joint reconstructive surgery circumstances are still evolving. The following case describes the use of platelet-rich plasma with autograft. A 61-year-old male presented with a closed type C3 tibial pilon fracture with significant comminution. His local physician had provided longitudinal traction and temporary reduction with spanning external fixation. Once the soft tissue swelling had diminished, the patient underwent open reduction and internal fixation of the articular fragments and autologous bone grafting, plus platelet-rich plasma composite grafting of the metaphyseal defect and shaft extension. 3 cc's of iliac tubercle cancellous bone was harvested percutaneously with a quick-draw bone harvester and blended with 6 cc's of autologous platelet concentrate, using the platelet concentrate system, Symphony. Articular fixation was secured with 2 screws, and shaft fixation included an Ilizarov circular fixator. Immediate postoperative X-ray demonstrates reduction and fixation. Progressive bi-week compression of the injury site with the external fixator provided increased fragment contact and stability. X-rays at 8 and 16 weeks demonstrate consolidating fracture sites. The fractures were healed radiographically and clinically, and the fixator was removed at 20 weeks. Final X-rays shown are at 8 months. The patient achieved full work and functional capacity without pain, but demonstrated mild ankle stiffness. In this circumstance, using bone graft to enhance healing of the shaft extension and fill a metaphyseal defect was necessary. The mixture of platelet-rich plasma with autologous bone graft allowed a more limited graft harvest. The following case study exhibits a novel way to manage a segmental acetabular protrusio fracture with a synthetic bone graft substitute augmented by autologous platelet-rich plasma, or PRP. An 81-year-old female with a history of type 2 diabetes mellitus sustained a left femoral neck fracture after a fall and was treated with cannulated screws. Postoperatively, the patient developed avascular necrosis of the left femoral head and experienced debilitating hip pain. The patient underwent removal of the screws and a left total hip arthroplasty. A protrusio fracture was created during acetabular reaming, which was addressed with a cemented polyethylene insert and a titanium screen. This proved ineffective. The patient then underwent a revision left total hip arthroplasty using a modified Hardinge approach. The well-cemented femoral stem was left undisturbed. The femoral head, acetabular component, cement mantle, and titanium screen were removed. The patient had an absence of the anterior wall with diastasis across the acetabulum. There was fragmentation with independent motion between the superior and inferior aspects of the posterior column. Progressive reaming was started at 48 millimeters and was carried out to 50 millimeters. A thin titanium screen was molded and placed within the former floor of the acetabulum. 40 cc's of conduit tricalcium phosphate, TCP granules, was clotted with platelet-rich plasma prepared by the Symphony PCS device. The clotted conduit graft was molded into a patty and placed within the confines of the acetabular protrusio fracture defect. A 54 millimeter revision acetabular shell was impacted in place and secured. An acetabular cage was used to bridge the ilium and ischium. A 36 millimeter polyethylene liner with a 10-degree lip was cemented to fit the acetabular shell. A plus 5 millimeter by 36 millimeter outside diameter femoral head was selected and the hip was reduced. 1 month postoperatively, the patient had minimal left hip discomfort and tolerated 25% weight bearing. Radiographs revealed no evidence of instability within the acetabular component bone interface and no evidence of bone graft migration into the pelvis. Radiographs taken at 2 months revealed increased bone formation across the inner table with reduced lucency about the acetabular shell. At 3 months, radiographs continued to show increased bone formation across the inner table without evidence of instability. Augmentation with platelet-rich plasma enhances bone graft containment and handling characteristics. Results from this case suggest that conduit TCP granules augmented with platelet-rich plasma may be an effective way to handle severe acetabular deficiency in revision total hip arthroplasty. This clinical example involves the use of a demineralized bone matrix in combination with platelet-rich plasma as a bone graft material. A 58-year-old female with a previous history of intramedullary nailing 3 years prior presented with an infected atrophic nonunion of the femur. This patient suffered from severe cardiac disease and insulin-dependent diabetes. Surgery was carried out with a staged reconstruction consisting of radical debridement and placement of an antibiotic-impregnated cement nail. 6 weeks following this initial procedure, resolution of her infection had been achieved. She then underwent revision open intramedullary nailing with platelet concentrate, PC, and demineralized bone matrix, DBM, augmentation. Autograft harvest was not considered due to the patient's significant health concerns. Following the second procedure, she achieved complete femoral shaft reconstruction at 26 weeks. At 14 months postoperative, the patient reported no pain and resumed her daily activities without noticeable limitation. Certain upper extremity and foot ankle applications require small volumes of bone graft, often not making it worthwhile to harvest the bone from the ilium. This 15-year-old boy sustained a proximal radial fracture and presented 2 years after a failed open reduction internal fixation had been performed. Chronic pain and clinical deformity were present. The radiograph demonstrates a varus deformity, overriding of the bone fragments, and an oligotropic nonunion of the proximal radius. A combination of 1 cc of harvested proximal ulnar bone graft combined with 2 cc's of platelet-rich plasma was used as the bone graft material. The nonunion site was prepared with open exposure, removal of fibrous tissue, and burring the bone ends to puncture bleeding points. Internal fixation with compression plating was performed. Early healing was evident at 6 weeks, and X-rays at 10 weeks post-repair demonstrated further union. Clinical photographs demonstrate restoration of functional range of motion. This case demonstrates the successful application of platelet-rich plasma with minimal harvesting of local autograft bone. The surgeon must combine appropriate biological treatment of the healing site with stable skeleton fixation for success. This 42-year-old male was seen 2 years following upper tibial osteotomy for medial compartment osteoarthritis, which resulted in excessive varus orientation. Despite 2 subsequent procedures involving grafting and revision of internal fixation hardware, the patient still presented with a painful mobile nonunion and persistent medial joint pain. Previous grafting procedures and obesity, 320 pounds, hampered the use of autogenous iliac bone. The nonunion site was approached laterally through the prior incision and all internal fixation removed. The nonunion site was prepared by removing all fibrous tissue and drilling and burring the nonunion surfaces to bleeding cancellous bone. Intraoperative gram staining and subsequent cultures were negative for infection. The OP1 implant, or BMP7 from Stryker Biotech, was reconstituted with 2 cc's of autologous blood to create a composite paste which was applied to both surfaces of the nonunion. The varus posterior translation deformity was corrected gradually. Fracture stability was achieved with circular external fixation using the Taylor spatial frame and associated computer software to achieve gradual postoperative correction to the mechanical axis of 4 degrees valgus. The nonunion site was progressively compressed 1 millimeter every 2 weeks for 8 weeks. Healing was clinically and radiographically evident at 12 weeks, and the fixator removed at 20 weeks. Full pain relief at the medial joint and nonunion site was achieved. There are no well-defined algorithms to help a surgeon select a specific type of bone graft substitute, or inductive factor. The use of these materials should be based on sound physiologic principles relating to the fracture healing cascade specific to the type of pathology being treated. For metaphyseal defects, it has been shown experimentally that a simple cancellous void will reconstitute and heal completely on its own without the addition of any grafting material given a sound biologic and mechanical environment. A danger may be subchondral surface collapse if the defect does not reconstitute fast enough to provide mechanical support to the articular surface. For primary metaphyseal defects, any osteoconductive substrate will be sufficient by itself to heal a well-vascularized void. This includes a multitude of calcium sulfate and calcium phosphate bone substitutes. In addition, autogenous, demineralized, or allograft bone grafts will also provide positive results, although using autogenous grafts may be unnecessary for these types of pathologies. The major goal of a bone graft in a metaphyseal defect is to provide a competent osteoconductive substrate to facilitate rapid consolidation and avoid articular collapse. The choice of any osteoconductive substrate should be based on its mechanical properties, as well as the material's degradation profile. Inductive proteins, such as recombinant bone morphogenetic proteins, are unnecessary in these situations. The true test of any bone graft material or substitute is its use for a midshaft diaphyseal lesion. Segmental bone loss remains problematic and usually requires significant quantities of graft material in combination with an osteoconductive extender or by itself. Osteopromotive factors, such as those found in PRP and osteoinductive factors, such as recombinant BMP or those found in DBM, can also be added to increase early bone formation responses. Problems here include the lack of rapid remodeling. These defects are prone to fatigue and stress fracture. Additionally, massive allografts only revascularize or neovascularize the outer few millimeters of graft material, and a large portion of the graft will potentially remain unincorporated and prone to giant cell infiltration and subsequent removal. Large segmental defects often require iliac or fibula bone transport segments. Bone transport segments remodel continually and are at low risk for fatigue failure, but require extraordinary surgical experience, patient compliance, and time. Transport segments represent a graft that provides living osteogenic cells, circulating inductive proteins, and large structural osteoconductive surfaces. Vascularized bone grafts are prone to delayed fracture due to the cortical nature and small diameter of the vascularized fibula. For these challenging situations, using combinations of novel osteoconductive grafts with osteoinductive factors like BMP and DBM and osteogenic cell enrichment technologies may help to alleviate the need for autograft harvesting. PRP, or platelet-rich plasma, may enhance the bioactivity level of these bone graft materials. For tumor or post-total joint salvage, large structural allografts are often indicated to provide the necessary mechanical support in addition to the skeletal replacement. In an effort for these large allografts to heal at their host allograft junction, inductive factors in combination with cellular substrates and conductive materials can be utilized, as can a cancellous autograft that would provide similar material properties. For smaller diaphyseal defects or straightforward non-unions, surgeons must be aware of the pathology being treated and tailor the surgical strategy to that pathology. For example, graft requirements are different when related to hypertrophic non-unions, where the biology is sound and the mechanical environment is suspect, or atrophic non-union, where the biology is deficient and the mechanics are inadequate, or infected non-unions, where mechanical, biological, and